Dr. Fitzgerald, before I turn it over to you about decoding the most challenging NB board questions,
Mm-hmm.
is there anything that you want to kind of set the stage for this evening before we start to talk about these and dig into what some of these questions actually are?
Well, just a reminder, what are the NP boards? The NP boards are not just another art hurdle put in front of you. You know, you get through your NP program, you're like, crawl, 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 you're finally there. And then you have this great big hurdle to get over. It's not an artificial barrier, but
Yeah.
the NP boards are actually a highly vetted way of allowing you to demonstrate you'll be safe to practice. It's as simple and as complicated as that. The role of the NP boards is to see if you possess and can apply the knowledge base needed to be a safe entry level NP. Now, I'm a family nurse practitioner, and I have been teaching in NP board review for more than 35 years. I've also been in practice in a primary care setting, a federally qualified health center, as a full lifespan family nurse practitioner. Pregnancy, the little ones, the ones in the middle, so the older ones, the really old ones, and everything in between. And I'm going to talk more from the view of the family NP, which does include about 3/4 of all NPs that are, well, yeah, together the family and the adult Gero NPs, it's about 3/4 of all NPs that are prepared. But much of what I will say will be helpful for the other boards too. So with that in mind, what do you say? Shall we
Let's
get
do
going?
it. Let's
All right,
do it.
very good. All right. So this is a little bit about my background, and sometimes I'm asked, why do you bother putting this in when you're speaking? One of the reasons is I want you to be aware of what you can do as an NP, because I'm assuming that most, if not all of you, are looking down a very short road to your NP boards. And right now, what you just want to do is you want to get through the boards and get past them and get your license and find an NP position. That's all you want to do. But I want to remind you that this is a tremendous role, being a nurse practitioner, where all sorts of doors are going to open up for you. Adjunct faculty at Case Western Reserve, which is where I did my doctoral studies. I'm on the editorial board of a number of different journals. Numerous times I've been the first NP to sit on an advisory board, because I feel really, really, really a great responsibility for helping to clear the road for other NPs behind me. I sit on the Pharmacy and Therapeutics Committee for a major HMO in New England. And that just kind of scratches the surface of what I'm able to do as a nurse practitioner. So one more time, test success tip. The purpose of the family and the adult Gero primary care NP certification exam is the measurement of your knowledge, reasoning, and, listen to these words, clinical decision-making skills in assessment, diagnosis, plan/intervention, and evaluation in primary, not specialty, acute, or emergency care. I'm going to tell you all something right now. You have, at bare minimum, you either have or you're about ready to have, at bare minimum, a master's degree. Many of you have 2 masters or postmaster certificate. More and more of you are graduating with doctoral degrees or postdoctoral certificate. Okay? You are an outstanding test taker. You would not be here with me tonight if you weren't. Okay, you are a really good test taker. So when people say, I need to work on my test taking skills so I pass the NP boards, no, you need to work on your clinical decision-making skills. That's the key. And that's what we're really going to focus on here. So which test questions on the boards are the most challenging? Oh, you're going to hate this answer. Every single one. They are equally weighted. They're not tricky because these, remember, The results of boards are used for regulation of NP practice because in virtually every state in the nation, unless you've passed the exam and you're board certified, and you can't get a license to practice. So these are within state law. So therefore, what you have to remember is the test questions, they're not tricky. There aren't simple ones and complicated ones. There aren't ones that gather less point value than others. No, 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 no. Every single question on the boards will be challenging. I know, aren't you glad you came in for this program? But here's the other part of it is that given that they are equally weighted, you have to take each one really, really seriously. And I want to remind you of just one other thing as you're getting ready for boards. You're getting ready for an exam that there's a very, very high bar to hop over before you even qualify for it. Because you have to have at least a master's degree, you need to have taken pharm, patho, physical assessment, you needed at least X number of clinical hours, et cetera, et cetera, et cetera. So to me, it is surprising and disappointing that 15% or so of the people who sit for this exam fail. One more time, aren't you glad you signed up for this? Aren't I just a bundle of joy?
This is why we're here.
Yeah, that's why you're here. And why do people fail boards? They fail boards because they either don't have the knowledge base or they can't apply the knowledge base to make clinical decisions. And far more often, it is a combination of the two. And that's the view we're going to take going over questions here tonight. So the first question to ask when you look at an exam question, and by the way, you could have done 10 bazillion million skillion practice questions. And what you're going to do is you're going to find that every single questions on the boards is a question you've never seen before. Okay, I can guarantee you that. But first question to answer when you look at a question is, what is the question actually asking? And this is the ADPI mnemonic, because the clinical decision-making process has 5 major components, usually performed sequentially. I taught in an NP program for a number of years, and sometimes my students would get to a plan without making up a diagnosis, and I was like, I don't know how you managed to do that. Your plan is actually right, but how'd you manage to skip that diagnosis part? But you've got to, that's how we have to take a look at questions first. So first of all, assessment. What is assessment? And this will be about 1 question in 4 on the exam, roughly 26%. And when you look at the different certifying agencies, you'll see that it's a little bit different. That's why I'm giving you rough numbers here. And the purpose of assessment is collecting subjective information like health history, including the history of present illness, and objective information, physical exam, and available diagnostic results. And what you should anticipate, because this is a test of entry-level NP practice, expect to be tested on the classic presentation of the disease and the outpatient setting. And I'm going to throw one other thing in here. Expect it to be found in a group, in a patient group who would most likely get this condition. Like, for example, unfortunately, I have diagnosed type 2 diabetes on kids as young as 9.5. Yes, it was type 2, it was not type 1, right? You're never going to see, for the family candidates, a 9-year-old with a new diagnosis on type 2 diabetes on the NP boards. You might get a question on new diagnosis of type 1 diabetes in a 9-year-old with the classic presentation, because when is the onset of type 1 diabetes? Most often in children. When is the onset of type 2 diabetes? Most often in middle-aged adults. So if you had a question on boards about diagnosing type 2 diabetes, it probably would be like a 40 to 60-year-old adult who's got risk factors for it. Okay. Diagnosis will be, again, roughly one question in 4 on the boards. And this is coming up with your differential diagnosis. And what you have to do is analyze the assessment data to determine a working diagnosis, keeping in mind common health problems seen in primary, not acute specialty or emergency care. And one more time, expected to present in the person who has risk factors for it. So one more time, the 45-year-old presenting with type 2 diabetes, probably they'll give you some information like strong family history of type 2 diabetes and a BMI of 35. Okay, so we've got 2 major risk factors there for that, for type 2 diabetes. So that's what you're going to see. All right. Then plan/intervention. ANCC divides plan and intervention into 2 different domains, and I'm not exactly sure why. AANP just calls it plan. And I always look at this and say, what, you're going to develop a plan of care, but not do it? No, because that's the intervention part. But anyway, we're going to mush those 2 together. That's going to be about 26% of the exam, or one more time, one question in 4. And develop and implement a plan of care, prescribe intervention to attain expected outcome. And remember, this test is all best evidence. And I know, in fact, there are people who teach NP review that will say, oh, the boards are like 2 or 3 sets of guidelines behind. Oh, no, 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 they're not. No, they're not. They're up to date. And the emphasis on the boards will generally be first-line interventions. Now, I will tell you, when I counsel people who have failed boards, they'll say, yeah, but it was all 3rd and 4th line interventions. I'll say, okay, so give me a general example of what you're talking about. And what it is the person is thinking, it was a 3rd or a 4th line intervention, when actually it was a 1st line intervention was the correct answer. So it was that the person that says it's 2nd, 3rd, and 4th line interventions. No, it generally is not. What it is the person who's telling you that it was way down the rabbit hole. It's just that they weren't aware of 1st line intervention. An evaluation is specifically looking at response to care, and that's about 1 question in 5. And so and what you are looking at there is the plan of care actually working? Is it stay the course? You know, going back to an example of somebody who's 45 with type 2 diabetes, you know, they've been on metformin for 3 months, they come back, their A1C is 6.8, they feel good, they're not as thirsty, they're not peeing as much, generally feel okay, then A1C 6.8%, stay the course. That's the evaluation. Well done, stay the course. So sometimes the evaluate part is just continue to do what you were doing before, or conversely, the person is 45 years old, has stage 3B, chronic kidney disease, on metformin, A1C, been on metformin for 3 months, has adjusted diet, A1C is like 8.2. Well, that's too high. And now what are you going to do as your evaluation? You're going to add another med and probably an SGLT2I, one of the gliflozins, because those are the darling of treating people who have both CKD and diabetes. So a lot of the pharmacology comes in the plan/intervention and the evaluate domains, but do not think it's only, that's all pharmacology. Do not, because your assessment skills are incredibly, incredibly important as well. So let's take a moment here and think about the ADPI mnemonic in the RN experience. As an RN, you do contribute to assessment. you do contribute data that allows you, that contributes to coming up with the diagnosis, certainly the plan and the intervention. But when you think about it, a lot of your RN practice has been evaluating response to care.
Yeah.
And that, just think, if you assumed the care of a patient at 9 o'clock who just got admitted or just showed up in the ED with heart failure exacerbation, what do you, and somebody other than the RN came up with the diagnosis, correct? You contributed data to it, but somebody else came up with the diagnosis. Somebody else wrote for the pharmacologic intervention. And what your job really focused on, it's evaluating whether that intervention is working. Is it not? So it's 9 o'clock, you see the patient for the first time, heart rate's up, respiratory rate's up. You can tell I'm making up this patient because it's an older adult. They're in the hospital, but they can actually talk. Okay. So they say to you, oh, I'm so short of breath. Respiratory rate's up, heart rate's up. 9 o'clock, meds have been adjusted. 10 o'clock, you notice the patient is diuresing really, really well. How you feeling? Not really much better, but heart rate still up, respiratory rate still up, the lungs still sound terrible, like a river's running through them. 11 o'clock, you go and evaluate the patient again. How are you feeling? Oh, my breathing is so much easier. Now, heart rate's still up, respiratory rate is still up, but down from where it was at 9. Lungs still sound terrible. But you've got a subjective measure, which is important, that the patient tells you, I feel better, and you've got an objective measure that heart rate and respiratory rate went down. So that's good. The patient's on the right track. Now, so that's evaluation. You're an expert in doing that. You are. Now, I'm going to mix it up a little bit more with the heart failure example. Same thing, 9 o'clock, start taking care of this patient. Heart rate's up, respiratory rate's up. How's your breathing? Oh, it's terrible. 10 o'clock, how you feeling? Really no different. You notice heart rate and respiratory rate haven't budged. 11 o'clock, the person says, I'm smothering. I'm smothering. Heart rate, respiratory rate even higher than it was at 9. You need to notify somebody to change the plan of care, do you not? Or maybe if you're working with protocol, you need to add a different med. But one more time, your role was largely evaluation. We're going to do the whole thing now as nurse practitioners, A, D, P, I, and E, right? So, which question are you more likely to get on boards, right? So these are the things that people are afraid they're going to get on boards. And they say to me when I'm teaching NP review, okay, which set of cervical cancer screening guidelines do I go by? Because ACOG has one set, US Preventative Services Task Force have another, American Cancer Society has another. I'm sure there's another set of guidelines rolling around someplace. Okay, which one do I memorize? First of all, get rid of the word memorize from your vocabulary for the boards. You conceptualize, you critically think, you hone your clinical decision-making skills. That's what you're doing. So this is an example of a question you will not get on the boards. You won't. So at which age does the American Cancer Society recommend cervical cancer screening start? Would it be A, onset of sexual activity, B, age 18, C, age 21, D, age 25? So what do I mean by factoid? You had to memorize something, didn't you? Yeah. You know, stuff that you can look up on your phone in 2 seconds does not show up on boards. That's why on boards there are no drug doses. There are no med calculations. Okay. There are no IV drip rates. Nothing along those lines. Okay. Because they'll say, okay, the prudent NP will look up drug doses all the time. And it's really funny when I'm in the exam room with patients and I'll say, oh, give me a minute. I want to look this up. And I'm old school enough because obviously I haven't carried a phone around with me my entire career, but I'll always say to them, I'm not making a phone call. I have medication information on my phone. And they go, oh, okay. And I look it up and I'll go, okay, yeah, I thought the dose was 20 milligrams, but just wanted to double check. And I've had patients say to me, I can't believe you have to look things up. And I go like, I look stuff up all the time. It keeps me humble and it keeps me safe. So anyway, so let's go back to this question here. Factoid questions are not going to show up on boards. I will tell you they show up right and left though in sample practice questions that will mislead you to think what are on boards, okay? So what's the correct answer here? The correct answer is actually age 25. That's what ACS says. However, at this very moment, 7/22 on February 24th, 2025, at this very moment, U.S. Preventative Services Task Force still says 21, but their guidelines have also been, quote, under review for years. And word is that they probably will go over and go with what American Cancer Society says too. So right now, when you've got two widely accepted set of guidelines that have different recommendations, you'll never, ever be tested like this. Okay, because one more time, it doesn't test your clinical decision making. So on the boards, okay, you're going to have about 135 clinical questions that count towards your final score if you're taking family or adult gero primary care. And to be honest with you, most of the other boards as well. All right. So do you think they're going to, when they're trying to figure out that whether you'll be safe to practice or not, do you think they're going to bother wasting two questions, one like this, ACS, cervical cancer screening? Okay, next question, when does U.S. Preventative Services Task Force and ACOG say to start it? Then the correct answer is 21. We're going to waste two questions on that because they only have 135 questions for you to be allowed to prove that you'll be safe to practice, okay? But this is more the question you're going to get. A 19-year-old woman, AFAB, or assigned female at birth, presents for health maintenance visit. She's without complaint or chronic health problems, and her current medications include combined oral contraceptives and reports being in a 2-year relationship with a male partner. All right. Now, you probably want more information about her than you're given. Read it and weep. You've got enough information here to answer this question. You've got enough, okay? Which of the following screening tests is a clinical priority for this patient, okay? So she's 19. She is heterosexually active, right? And would it be A, cervical cancer, cervical pap with HPV testing? B, no specific tests advised given she is without complaint. C, chlamydia and gonorrhea screening. D, hematocrit and hemoglobin. Now, you're not allowed to say, yeah, but I want to do more than one of these. Nope. This is priority. So now what you have to do, you have to look at a question like this and say to yourself the following. Does it say anything like she has super heavy periods? No, it doesn't. That she has an eating disorder, so we'd be concerned about anemia. No. She's on birth control pills. She probably has very, very, very light periods. However, what do we know? People, particularly under the age of 25, what do they have the highest rate of in the general population? Sexually transmitted infections. And what's the most common of the STIs around that we can easily screen for. And it's chlamydia. So here is a way of looking at this question. Look at the last sentence in the stem. And the stem is the story of the question. Which of the following screening tests is a clinical priority? And when words like clinical priority are used, what they're saying to you is, which condition here could we test her for that would get, she has the highest likelihood of having, given her history, and that we're going to get the most, shall we say, return on investment out of, right? So that's what you want to do. Look at the last sentence of the stem or the story of the question. Now, as I say that, looking at that last sentence of the stem or the story of the question, it'll give you an idea of what the question is all about. But I am not saying do not read the rest of the question, because I've had people say, oh, yeah, I heard somebody who is a test taking expert who said, just read that last sentence and you'll be able to answer it. No, because then the answers mean nothing without her story, okay? So when we look at this, we want to think of principles of health screening focused on the population who is at highest risk for the condition in the asymptomatic state. It allows for early case finding and intervention to minimize the risk of more serious health issues. So a 19-year-old is part of the greatest risk category for HPV, high-risk HPV and cervical cancer at age 19? Not really. And why don't we start cervical cancer screening and high-risk HPV testing till age 25? Because there's a good chance that she could have some HPV on board. But very often, if you just do a little watch and wait, by the time a woman's cervix gets fully mature, which it does not get until she's in her early 20s, any HPV that's been hanging around for a while, the body takes care of it and puts it under control. Is she at high risk for gonorrhea and chlamydia? Yeah, this is what she is at highest risk for, because who do we see the most chlamydia and gonorrhea in? It's young adults age 25 years and under. Anemia, you might say, yeah, but she's a younger adult female. Wouldn't she be anemic? No, without a report of heavy menses. The other thing is, and by the way, this is not called reading too much into the question, but she's on birth control pills, so you know her periods will be very light on birth control pills. So you have to know a little bit of epidemiology here. And you might say, yeah, but she has no complaints. If she has gonorrhea or chlamydia, isn't she going to have vaginal discharge, painful intercourse, et cetera, et cetera? Not really. The majority of people with those two conditions are in fact asymptomatic, and that's why there is a recommendation for universal screening, 100% screening of females aged 25 years and younger for gonorrhea and chlamydia. The recommendations for assigned male at birth are a little bit different. They're in higher risk groups and things along those lines. Where I practice, we just screen everyone and we get a lot of positive chlamydia. Gonorrhea is just not as common. There's probably 8 cases of chlamydia nationwide to every 1 case of gonorrhea. Okay, so that's what we want to keep in mind. So then, of course, the correct answer here is C, chlamydia and gonorrhea screening. And just a couple of things to keep in mind with this. The chlamydia and gonorrhea screening, it can be done by urine testing, which is highly effective. She is she's 6 years from needing to have a PAP or an or HPV testing done. She is. So you would not do this now. And I know that there are still some kind of old school providers around there. A lot of them look like me because they're older like I am, and they'll say, oh, but I still want to do that annual PAP. A lot of times, and I want to start the PAPs before age 25. Remember, just because we're not doing PAPs and HPV testing, it doesn't mean we can't do STI testing. And that's really, really critically important. And you might say, yeah, but if they're asymptomatic, why bother treating gonorrhea or chlamydia? Tubal scarring, pelvic inflammatory disease. She's walking around with an infectious disease she could give to another partner. You know, the list goes on and on. So we do want to make sure that she gets treated. Okay. So test success tip, don't confuse what you've seen for plan/intervention in your acute care RN practice with what will crop up on primary care boards. So we've got a 70-year-old who presents with community-acquired pneumonia. And what to consider. All I'm saying right now is 70 has pneumonia that was acquired out in the community. So not on a ventilator, not in a healthcare facility, nothing like that, okay? What to consider with just that little nugget of information. First of all, the boards will want to see how you handle treating a person with a potentially life-threatening condition. And if we can kind of push COVID to one side, which is pretty hard to do over the last 5 years, and look back historically, what has been the #1 cause of infectious disease death overall in the general population? It's actually pneumonia. It's actually pneumonia, which comes in overall now that the COVID death rates are way, way, way down. It's back to pneumonia is like the #8 overall cause of death in the United States, okay? So here is something that you might say, oh, but everybody with pneumonia gets hospitalized. No, they don't. For every 1 person on the medical floor, 100 people are treated as outpatients. 100. Okay. For every 1 person in the ICU with community-acquired pneumonia, 500 are treated as outpatients. So the majority of people with pneumonia are actually treated as outpatients. And even some rather fragile older adults, we move heaven and earth to have them cared for at home by rallying, community support, family members, visiting nurse, whatever we need to get into the household, because hospitals are tough places for older adults to be in, right? Okay. So what you're going to get with your 70-year-old with community-acquired pneumonia, it's not going to be the scenario where, what do? Oh, you dial 911 and get the person out of your office. No. They're going to want to see how well you know how to treat this patient as an outpatient, albeit with very close follow-up. So what answers overall on the family and the adult gero boards are seldom right, regardless of the clinical scenario? What answers? Just, you could take this to the bank. 2 things that are seldom right. 1 is send to the ED. That's hardly ever the right answer. And you know why? They're going to give you a scenario of a person like with pneumonia who you can treat as an outpatient. Okay. The other answer that's seldom right is refer to a specialist, like an 18-year-old with acne. It wouldn't be just refer to derm. No. We can do a lot to help people out with acne. We can, and we should, because people with acne suffer. They suffer with this. And so to just say, refer to derm and don't do anything will simply not be the right answer, okay? So safety rules. This is an older adult, higher risk for poor outcome, our 70-year-old. What do you want to do when you're treating community-acquired pneumonia? Ensure the gut works, because I'll let you in on a secret here. Antibiotics work just as well as parenteral antibiotics, just as well. And I'll give you a quick and dirty, I teach pharmacology, so I always go back to my farm rules. What's the dose for a daily dose of levofloxacin IV for community-acquired pneumonia? It's 750 milligrams IV. Guess what the dose is, PO? 750 milligrams. That tells me PO levofloxacin with an intact gut has 100% bioavailability. So giving it IV, there's nothing magic. In the inpatient setting, you do see some antibiotics that are only given parenterally, but we're not having people walk around with IV lines in, okay? So a few things that you want to do. You want to make sure the gut works, so PO drugs can be used. Plus, on top of that, they can hydrate and stay nourished. Mentation is intact. They have support at home, that's critical, and you want to avoid diagnosis. So just with me telling you it's a 70-year-old with community-acquired pneumonia, the diagnosis has already been made. Therefore, this is a plan/intervene question, and you need to practice best evidence with first-line medications. So what are the bugs that cause community-acquired pneumonia in older adults? These are the bugs: Streptococcus pneumoniae, gram-positive, and strep pneumo is the one that's most likely to kill a person with pneumonia, okay? Haemophilus influenzae, gram-neg, and then select atypicals, including M. pneumoniae, C. pneumoniae, and Legionella. And, you know, Legionella, I'd almost push to one side for the boards because it's not that common a cause of pneumonia. It's probably more common than we realize, but an 18-year-old with Legionella goes around with a dry cough for a few weeks and gets over it and is none the wiser. A 68-year-old with type 2 diabetes who has an A1C of 10 and smokes cigarettes is intubated, ventilated in the ICU. Yeah, they get really sick with Legionella, okay? So here we go. We have a 70-year-old man with COPD, dyslipidemia, and hypertension. He presents for an urgent care visit and is diagnosed with community-acquired pneumonia with a CURB score of 1. Now, I'm going to stop there for a moment. CURB score. It is a 5 number, it's a 5-question questionnaire for evaluating how people are doing with pneumonia. He has a CURB score of 1 simply because he's 65 years or older. It's what's called a non-modifiable evaluation. But CURB score of 1 means he does not have deranged vital signs. He's not confused. You know, and he does not show signs of severe dehydration. So that's pretty much what it means. His current meds include inhaled long-acting muscarinic antagonist, along with a long-acting beta-2 agonist, so a LAMA-LABA combination, an ACE inhibitor with a thiazide diuretic and a statin, as well as short-acting beta-2 agonists as needed. He denies drug allergies. He's taking fluids without difficulty and lives in an apartment. In other words, he lives with some other human beings. So now what you have to do is say, gut works, oral antimicrobial therapy is acceptable. There's nothing alarming there. And we're given 4 antibiotic choices. And this is what I hear from people quite often. I have 4 choices of antibiotics. Which one am I supposed to choose? Okay. Well, I think I've made my point that we're not going to go with the IV antibiotics. So we're going to take a look at B, 5-day course of IV piperacillin with tazobactam. That is sometimes used in the inpatient setting for select bugs, not as much with pneumonia, but with some other things. But looking at option B, this to me is what I call, this is a familiar choice. You've seen patients on this. You've maybe hung that drug. It is your old friend, even if you've only seen it once. But it's IV, so we're going to get rid of it. All right. Look at option D, 3-day course of injectable ceftriaxone. Same deal. Ceftriaxone might be like your best buddy. But one more time, it's injectable. We don't need to give him an injectable drug. So that gets rid of D. By the way, ceftriaxone would take care of the strep pneumo and the H flu, but not the atypical pathogens. So it's an incomplete drug anyway. So now that leaves us with A and with C. And what you have to do here is now think through what some of the characteristics of antibiotic in A, the clarithromycin, and the 5 days of levofloxacin. Clarithromycin, macrolide antibiotic, loaded with drug interactions. It's cytochrome P453A4 inhibitor. You're now a prescriber. You need to know stuff like this. Okay, you do. It's not recommended in any pneumonia treatment as a preferred therapy for a variety of different reasons. So now, obviously, we're down to, we got rid of the 2 parenteral. We're getting rid of the clarithromycin because of the drug interactions, and we're down to a 5-day course of oral levofloxacin, which is the correct answer, because it will cover strep pneumo, H flu, and the atypical pathogens. Okay, so it will do the whole bit. And if you look and you go, yeah, but 5 days, that's not very long. Nah, it's not very long, but this is evidence-based and is held within the Infectious Disease Society of America guidelines for community-acquired pneumonia, the American Thoracic Society guidelines for community-acquired pneumonia. It's mentioned as a preferred drug with the Sanford Guide. I mean, over and over and over again. Now, the other thing that it could be when we're talking about oral, it could be a mox with clavulonate plus doxycycline, and you add on the doxy because of the amox with clav will not take care of the atypical pathogens. And by the way, if you're going like, oy, 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 this is a lot, we go over all of these in the Fitzgerald review course. In fact, we're the only NP review course on the market specifically aimed at helping you improve your test performance through helping you enhance your clinical decision making.
Yes.
So where in the ADPI continuum is the next clinical scenario? This is a next step question. 45-year-old woman presents as a new patient to your practice. She's without complaint, is taking no medication, and states she's in good health. Today's exam reveals a BMI of 32. Her BP is 158/92. Heart rate 88 at rest, respiratory rate 16, temps okay, HENT, cardiac exams within normal limits. Which of the following is the next most appropriate, the next most appropriate steps are which of the following? All right. So what do you get from just that little nugget of information? She's a new patient. She says she's in good health. She doesn't take meds. I know we've all taken care of that patient that says, I don't take any meds. And then they rattle off 12 meds. Okay, we've all been there. On the boards, if it says she has no meds and she's in good health, she has no meds, she's in good health, let it go. 2 out-of-range measures are noted on a clinical exam. Her BMI, 32, so she does have the diagnosis of obesity. And of course, her blood pressure is too high, okay? Is it, oh my God, too high? No, but it's too high. No complaint, BP is elevated, but without hypertensive target organ dysfunction. And how do I know that? Because it said HENT within normal limits. She has no hypertensive retinopathy. Cardiac exam was okay as well. No S3, no S4, no murmurs, no shifted BMI, no neck vein distensions. See, folks, you have to be able to extract that data out of something super, super short that you're told like this. So where on the ADPI continuum are we? Well, you can now prescribe medications, right? So do you go ahead and do that, or do you do something else? So let's take a look at A. A, order a basic metabolic profile and advise about a lower sodium diet. So that's a mix of assessment, because that would be the metabolic profile, and intervention, the lower sodium diet. Okay. But on average, how much does blood pressure go down with a lower sodium diet? About 5 millimeters of mercury systolic, and that's it. And her blood pressure would still be too high. Would it be B, because you now can prescribe hydrochlorothiazide, which you do know is one of the first line antihypertensive meds, and arrange for a 2-month follow-up visit. So that would be intervene plus evaluate. Would it be C, arrange for at least 2 additional BP measurements on 2 different occasions with 1 month with a follow-up visit in 1 month? So that would be additional assessment, because you're getting more blood pressure measurements, and then you're arranging for evaluation. You want to see her back. Would it be D, order ambulatory blood pressure monitoring with advice on increasing physical activity? So check her blood pressure more with ambulatory blood pressure monitoring, which is, if you're not familiar with it, is the BP equivalent of a Dexcom. It's what it boils down to. Okay. And then advice on increasing physical activity, which we know is heart healthy. So what's one of the key points here? Do we want to do the metabolic profile and lower sodium diet? No, no. Prescribe the hydrochlorothiazide with a 2-month follow-up? No, we don't have a diagnosis of hypertension yet. Don't go treating something we don't know yet whether she has or not. C is the best answer, because what we have to do is since she has no hypertensive target organ dysfunction noted, we need at least 2 different blood pressure measurements on 2 different occasions within the next month, and then see her back. And then we'll make our diagnosis of hypertension. Now, truth be told, we're probably going to get the basic metabolic profile on her today anyway. We probably are. And also get lipids and things along those lines. But this is a good example of the best answer is C, because it says we need more assessment data before we have the diagnosis of hypertension, because she does not have any evidence of hypertensive target organ dysfunction. Okay.
Dr. Fitzgerald, I'm just going to hop in and just remind the group that we have about 10 minutes. So if you have
Yes, and now we're turning it over to questions and comments. So
yes,
now, did it look like all the questions were the most difficult? What do you think?
a little bit. I will say this, what hasn't changed, which maybe is nice for me as an RN to see on these questions, is that those best answers, that's still a thing. That's still a
Best
thing.
answer is still a thing. You should often count on 2 answers looking plausible. And when I go back to this last one here, I would say A's not a bad answer, but it's not the best answer.
Yeah.
Because you'd be getting that metabolic profile, and who, present company included, couldn't use to cut back on the salt in the diet a little bit.
Right.
Okay. And looking at D, ambulatory blood pressure monitoring, one of the things with that is that's considered to be a very much a second line way of monitoring blood pressure. It's fairly expensive. And I was joking, saying, well, it's like the Dexcom, the continuous glucose monitor of blood pressure. But whereas Dexcom, it's a little whatever on the back of your arm or wherever people put it. This is walking around with a blood pressure cuff on your arm. It's not quite as inconspicuous as walking around with a Dexcom, and it's actually pretty expensive, pretty expensive.
Yeah.
So anyway, but B is definitely not the right answer. And I'll throw one other thing in there, is that the AHA ACC guidelines on hypertension, they're really crystal clear that if you do something like you wait a month for follow-up. If you add a med, adjust a med, it's a month for follow-up. So,
Yeah.
all right. So questions.
A couple questions here. On the first one, and not a stupid question. What's C pneumonia?
C pneumoniae, it used to be called chlamydia pneumoniae, which has nothing to do with chlamydia trachomatis. And it's got, I wish they didn't do this to me, but they changed it. It's like chlamydiophile or something like that. It's something else. But let me just give you quick and dirty. M. pneumoniae and C. pneumoniae are lobbed together and called, they're usually referred to as the atypical pneumonia pathogens. And they're the two most common. They're cough transmitted. I've got one of them. Your face, tag, you're it. They also they're unusual for bacteria too, and that they have a pretty long incubation time. So very often what you'll see is an outbreak of M. pneumoniae or C. pneumoniae in people who are in close quarters with one another. So think military barracks, college dorms. One of my high school age grandchildren had M. pneumoniae a year ago. It ran rampant through her high school. The high school probably has about, I don't know, 600 kids in it or something like that. They were rotten with it, but they're teenagers. They're all in each other's faces, that type of thing. Sometimes outbreaks in long-term care facilities. And they're called atypical because when people have them, they probably have a dry cough. They're more miserable than sick, and they're sometimes called walking pneumonia. Walking pneumonia. And the incubation time, I kind of interrupted myself on that, is between 1 to 3 weeks. So the first person in a cohort comes in on the first of the month and goes, coughs all over everyone. It might not be till the 21st of the month before the next person gets sick. So it's quite different than a virus because, the first person in a cohort with like a viral URI, just regular old cold, walks in, coughs all over everyone on the first of the month. Everybody knows by like the second, the third, or the fourth, probably more like the third and the fourth, if they picked up that person's cold. So,
All right.
other questions?
Yes. Another question here. We got a couple more. Should we plan to review all the USPSTF recommendations? There are a lot.
There are a lot. And this is one of the things that we really highlight in the Fitzgerald review. You could screen for practically everything. There are all sorts of different guidelines and very appropriate within certain patient populations. What's going to come up on boards? Screening for the most common conditions that we find early that make a big difference. So when we go over that section, what we do for cancer screening, we'll talk about the HPV-related cancers like cervical cancer screening. We'll go over the lung cancer screening, breast cancer screening, dyslipidemia screening. type 2 diabetes screening. So I think you get the idea. It's the screening related with the major common clinical conditions that are picked up. And the other thing, and I can't say this strongly enough, loudly enough, different well-recognized organizations often have differences in their recommendations. I just went over this. ACS versus US Preventative Services Task Force. Okay, there were two different sets of recommendations for cervical cancer, right? Screening right now, too. You will never, ever get a question on boards that will put you between that rock and a hard place. Like I gave you an example of a 19-year-old. That was really clear. Nobody says she needs to be cervical cancer screened. But you might also get the 25-year-old who's never had cervical cancer / HPV screening done. And the question is, would you do this on her? And the answer would be yes, because everyone's in agreement that if a woman has hit age 25 and she's had none of this screening done, 'tis time to start. I hope that makes sense to people. Like, I'm going to give you another example. JNC 8 says diagnosing blood pressure when you're above 140 over 90. American Heart Association, ACC/AHA says above 130 over 80. Did you notice the case I just gave you was, I don't know, 150 and some change over 90 and some change? Didn't matter which set of guidelines you went by. Her blood pressure is too high.
Mm-hmm.
So that's what you're going to get on boards. When there are well-recognized sets of guidelines with some differences in their in what they recommend, you'll never be tested on those little margins. You'll be tested on what both guidelines will say.
Got it. All right, we got 3 more. Let's see if we can get them in. All right,
Yes.
this one says, what questions on boards have you ever seen the answer as send to the ED or refer to a specialist?
Virtually none. Now, somebody comes in, diaphoretic, 60 years old, the elephant standing on my chest. Yes, do me a big favor. 911. Bye-bye. Okay. That took 0 clinical decision making. Well, I shouldn't say that, but like everybody would know that, correct? That's what you do. Even something like anaphylaxis, it's not send right to the ER. It is give epi, get in a supine position, give an H1 blocker, give an H2 blocker. Okay. We're doing all these things while we're getting the heck out, getting them the heck out of the exam room, right?
Mm.
So we're not like, oh, well, you're going to the ER, they can give you the epi there. No, because it could cost somebody their life.
Yeah.
And let me just kind of bring it home when talking about refer to specialist. I'm going to go back. This is a simple example, acne. Okay. I have 6 months of work that I can do with somebody before I say, okay, you need Accutane. 6 months worth. So that means systemic antibiotic, topical retinoid, topical antimicrobial, maybe an anti-androgen. Do you see I've gone through like 4 iterations of treating that acne? And then I'll say, okay, now you go to derm.
Mhm.
So most of the time, the NP will have done a number of different things before somebody needs to go to a specialist. And the boards don't get that far. They don't drill down that far. They don't. They have 135 questions to determine whether you're clinically competent or not,
Yeah,
and that you will not be unsafe to practice.
it's a good reminder.
Yeah.
Yeah.
But you're going to find it over and over and over again in board review questions. Send to specialists, send to the ER. Doesn't come up on boards.
All right, we got two more here. This one says for PNA, you mentioned that macrolides are not recommended in any pneumonia treatment, but I thought an alternative treatment could be augmentin plus azithromycin.
I said first line. So the macrolides are not first line. They are mentioned, but azithromycin along with augmentin, amoxiclavulanate, is a possibility. I tend not to go that way with the azithromycin because you're giving it to cover the atypical pathogens. But clarithromycin, azithromycin also have the propensity to prolong the QT interval and induce ventricular tachycardia, ventricular fibrillation. Who are they most likely to do that in? Older adults. So most med questions are safety questions. I don't think you're going to come that find that as the preferred answer. It would be amox with clav with doxycycline, because doxycycline doesn't prolong the QT interval and has great atypical pathogen coverage.
Okay, awesome. And this last question, this pairs back to the C. pneumoniae question. I'm saying good to know, so thank you for
By the
that.
way, M. pneumoniae is much more common than C. pneumoniae. Just
Okay,
okay.
that's
Treated
good.
the same way.
That's a good reminder. On that same token, where does Klebsiella pneumoniae come into play? I've been
Oh, in
asked
the
about that
ICU. Get your head
several
out of the
times.
ICU. Or you're gonna flunk boards. You're gonna flunk boards.
It sounds like they've gotten that question several times as a atypical presentation. They've been asked about it.
No, first of all, who gets Klebsiella pneumoniae? Intubated, ventilated people can get it. Okay. We're pushing them all to one side. Out in the community, the rare time you'd run into Klebsiella pneumonia would be a person who likely has longstanding COPD, has been hospitalized, likely intubated, got colonized with it, probably is a heavy alcohol drinker. Okay. So it's way, 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 way down as the mega outlier. And that's what I sometimes say when I'm teaching NP review. I go, you have to get your head out of the ICU.
Hard to do.
Oh, it's very hard to do.
Hard to do.
Like when people say to me, well, why don't we do blood gases in primary care? It's like, do not give anyone any ideas. But then the other thing is when it comes to send to the ED, when do we do blood gases on people with asthma? And Jonna, you're a big peds person, so this even would apply to your little squirts. We oftentimes will see blood gases done when the decision is being made to intubate somebody. So by the time somebody is so distressed with their asthma that you're thinking about intubating them, they're not in your exam room. They have, they have been out of your exam room for quite some time.
Right. That's a great point. That's a great point. Dr. Fitzgerald, share this before we wrap up. I love this.
Oh, the 7th edition of my book,
Yes.
is coming
Yay.
out at the end of next month. So please don't go asking the people at FHEA yet for your copy, but the 7th edition will come in. It's going to be available. It's coming from the publishing house literally like March 31st. So we'll be ready we'll probably have it in around the 1st of April.
Yes.
So I'm very, very proud, 7th edition of the book. So
We are so excited. And I see someone's already ordered. So yay. Good for getting it.
yay, yay, yay. So
Excellent.
anyway, okay. Well, thank you all. What a delight it has been. Thank you, Patricia. Thank you, Jonna. It's
Welcome.
always delightful to do things like this. And I wish you all the very best as you get ready for your NP boards, and welcome to the very best work on earth, being a nurse practitioner.
Absolutely. Thank you so much for your time, Dr. Fitzgerald. Thanks again, everybody. We're glad you enjoyed it. Have an awesome night.
Take care.